friends, today we will be covering antifungal drugs for pharmacology. This is not only important from the view of pharmacology but also important from view of oral pathology and oral medicine, when also clinically, where we prescribe antifungal agents for various antifungal infections, which are the potential MCQ topics for the NEET preparation. So here I will be covering the brief concepts of how Antifungal Drugs Act and the important points of the various antifungal drugs. So to know how the antifungal drugs would act, first of all we need to be clarified about how the fungal cell is made up of. Right, so the most potential part and the resistance part the fungal cell has is the cell wall and cell membrane. Right, cell wall, it is basically made up of chitin, which is nothing but long chain amino acid, that is N-acetyl glucosamine, and carbohydrate sugar, that is glucans, that is most probably they are beta chain glucans, that is beta 1,6 and beta 1,3 type. Some of them also have alpha type, that is 1,4 alpha glucans, and they are made up of proteins, that is most probably in the form of nanoproteins. Now coming up to the cell membrane, the cell membrane of fungal cell is made up of ergosterol, unlike in human, which is made up of cholesterol. Right, so and the drug would be acting at the process of DNA synthesis or the synthesis of proteins and acting upon the fungal cell. Now how the fungal cell would be attacking. Right, so basically whenever we are planning for an attack, what do we plan? Right, how to attack from the entry and how to make the entry weak. Right, so similarly these drugs act. They act on cell wall, they act on cell membrane. Right, they act on the component which is helping the formation of cell membrane. Right, and they are creating pores and inhibiting the cell division and inhibiting the protein synthesis. Right, so now we have the drugs which are acting upon the cell wall. These are basically nicomycins. Nicomycins, they inhibit the chitin synthesis. Right, then we have echinocandins, that is caspofungin drug, which specifically acts on 1,3 beta glucan, and they inhibit the component that is making up the cell wall. Right, so we are inhibiting the components which are making up the cell wall, so we are inhibiting the cell wall formation. Next, coming up to the cell membrane. Right, so we have ergosterol, which is the component of cell membrane. So now we would be acting upon inhibition of the ergosterol formation. So now how is ergosterol formed? Right, so we have sanquilin, which in the presence of sanquilin epoxide would be converting into lanosterol, and lanosterol, which would be in presence of P450 14 alpha dimethylase, would be converting into ergosterol. Right, so we have drugs which would be changing the membrane permeability by inhibiting the formation of lanosterol and ergosterol. So we have terbinafine, which would be inhibiting the ergosterol synthesis by acting upon sanquilin epoxide, and we have azol's group of drug which would be acting upon 14 alpha demethylase and inhibiting the conversion of lanosterol to ergosterol. Right, now what ergosterol is formed, so how we will inhibit that, and once the cell membrane is formed, how we would be acting upon it. So we have amphotericin B. What does amphotericin B does? It binds with the ergosterol and forms the artificial fungal pores. Right, the cell pores are made. So what, when the pore formation is occurred, there would be the cell contents would be leaking out of the cell, and as this contents leak out, that would be leading to a cell death. Right, and amphotericin B is the widest antifungal drug we have the spectrum. Right, now there are microtubules in our cell, as we know. What do microtubules do? They are helpful in spindle formation during the cell division. So what we would be doing, they are mostly present in microtubules, are there in dermatophytes. So we have grease of fulvine, which will be inhibiting this microtubule formation. So as a result, what we are inhibiting? We are inhibiting the cell division of fungal cell in this way and inhibiting the process of cell synthesis. So from all, and we now have, that is protein synthesis, one of the most important aspect in the formation of cell wall, right? So how we would be inhibiting this protein synthesis? That would be through flucytosine 5, that is 5-FC. This 5-FC, in the presence of enzyme permease, can enter into the cell. This 5-FC would be converting into 5-fluorouracil in the presence of enzyme cytosine deaminase, right? So this 5-fluorouracil then would be converting into 5-fluorodeoxyuridine monophosphate, right? And this, in the presence of thymidylate synthetase, would be converted into deoxythymidylate monophosphate and help in the synthesis of DNA, which would be further leading to the synthesis of protein synthesis. So this drug is acting on the inhibition of thymidylate synthesis, thus inhibiting the DNA sequence formation and inhibiting the protein synthesis, right? So what did, in a brief, we have the drugs which would be acting on cell wall, drugs which would be acting on altering the membrane permeability, drugs which would be inhibiting microtubule formation, and drugs that are inhibiting nucleic acid synthesis, right? So now coming up to the classification. As we got to know how and where they are acting upon, now we can easily classify it. So inhibiting cell wall synthesis, so which drugs would be there? Remember back, entry, cell wall, that is echinokinin, that is caspofungin group, and nicomycin, which inhibits the chitin synthesis. Now this caspofungin is group, belongs to a group of drug, that is the newer group of antifungal drugs we have, that is echinokannidins, and they are mostly used intravenously, and the other drugs which are included in this group are micafungin and anidulafungin, right? Then we have drugs which will alter membrane permeability. So which were those? Number 1, we had terbinafine, which was inhibiting the sanquilin formation to lanosterol formation. That is all this group of drugs, terbinafine, butenafine and naftifine. These are ergosterol plus lanosterol inhibiting drugs. Then we have azoles, which inhibit the conversion of lanosterol into ergosterol. There are, based upon their structure, we have two types, that is triazoles, and which are having 3 nitrogen group of structure, and imidazoles, right? So triazoles include fluconazole, itraconazole, voriconazole and posaconazole, right? And we have imidazoles which include ketoconazole, so FIVP, right? FIVP is triazole, and KCB, right? It is a ketoconazole, clotrimazole and butoconazole, which are the imidazole group of drugs, KCB and tri-5-VP, right? This way you can remember. Then we have a Pauline's group of drug, that is Amphotericin B, nystatin and hamycin, that is HAMYCIN, hamycin group of drugs. Then we have a drugs which would be disrupting microtubule formation, that is the grease of fulvine, and grease of fulvine is one of the systemic drugs which we use for superficial skin infections. And then we have drugs which will inhibit nucleic acid synthesis, that is flucytosine, that is 5-FC. Now here we have Fluconazole, which is the only drug which will be acting against mucormycosis. This is the important point to remember. Further we are also going for the other drugs and the important factors of them. Now coming into the important points of various drugs, that is we have number 1, we have Fluconazole. You know, one of the most common drug we prescribe as an antifungal. So Fluconazole is a drug of choice for candidiasis, cryptococcal meningitis, and it is used for prophylaxis of febrile neutropenia, right? Fluconazole is for prophylaxis and what? For the treatment of febrile neutropenia. So drug of choice for the treatment of febrile neutropenia is voriconazole. Clear about it? Now we have itraconazole. Itraconazole is a drug of choice for blastomycosis, histoplasmosis, coccidomycosis and paracoccidomycosis. And we have the another group, that is ketoconazole. It is also having, it inhibits the cytochrome P450 enzyme reaction, right? So it is important for the point of aspect of drug interaction, because as we inhibit, there are drugs which increase the P50 enzymes and there are drugs which decrease the P50 enzymes, right? P450 enzymes. So we know that the drug interaction would vary. That would be synergistic effect or an inhibitory effect to other drugs. So is ketoconazole important antifungal drug from the point of view if to be prescribed with other drugs, right? This would we would be covering it in later on. Now we have a newer group of drugs, as we said, caspofungin, which where does it act? 1,3-beta glucans, right? So these are the only approved drugs, and this will be used only in the cases where invasive aspergillosis is not responding to voriconazole or amphotericin B, right? Clear about it? Now coming up to voriconazole. Voriconazole is used for DOC of febrile neutropenia, and also it is a drug of choice for invasive aspergillosis, right? Clear up till now? And now we have some of the topical drugs which are used. So these are Whitefield's ointment. You know, you might be asked what is the composition of Whitefield's ointment. So you need to remember it is basically benzoic acid with salicylic acid, which is topical antifungal drug. Then we have Pauline group nystatin, which is used for oral candidiasis. And if it is topically for oral candidiasis, and nystatin is given orally for gastrointestinal fungi. Clear? So you would be confused. If it is oral candidiasis, it is topical. If it is gastrointestinal fungal, then nystatin is given orally, that is systemically. Clear about it? Keep a note on this point. Then we have toinaftate and anticlinic acid, and imidazole, ketoconazole, butoconazole. These are the azoles which are used as a topical drug. Now coming up to a most important drug, that is Amphotericin B. It is having a widest spectrum of antibiotic, and it is used for as a co-infection for systemic fungal infections, and it binds to ergosterol, as we said, forms artificial pores and inhibits, creates the spores and leads to cell death, right? So now what is the disadvantages of Amphotericin B? As it leads to dose limiting nephrotoxicity, and it can lead to acute infusion related reactions, hypophosphatemia, anemia and hepatic dysfunctions, right? There are lipid formulations available for Amphotericin B. There are Amphotericin B lipid complex, Amphotericin B colloidal dispersion complex, and liposomal Amphotericin B, right? Now, what is the advantage of this lipid formulations of amphotericin B? These are that it leads to milder acute reactions, can be used in intolerance to conversion of preparations, have low nephrotoxicity and anemia, and deliver of amphotericin B to RES of liver spleen is so useful in leishmania and immunocompromised patients, and it can be given in the higher doses, right? This is the advantages of lipid formulations of amphotericin B. Now coming up to the interaction, as I said that we have a ketoconazole that inhibits the cytochrome P450 enzyme, right? So as this occurs, cyclosporine, phenytoin, tolbutamine, this serum concentration increases, right? So ketoconazole is basically to be contraindicated with amphotericin B. We must not give in the combination of amphotericin B, as it is inhibiting the action of amphotericin B. Now coming up to the combination of amphotericin B with flucytosine, right? So both this drug, when given together, it occurs acts in a synergism, right? So how it is advantageous, that is entry of 5-flucytosine, it reduces the toxicity, there is a rapid culture conversion, reduction in duration of therapy, and decreased resistance, right? So this is the advantage. So flucytosine and amphotericin B leads to synergism when given together. And voriconazole, the adverse effect of voriconazole is that it prolongs QT interval, and it causes visual disturbances, and that is called blurred vision, altered color perception, and photophobia. And as we discussed previously, posaconazole is the only azole that is active against mucormycosis. So to be in brief, we have for blastomycosis we have itraconazole, mucormycosis we have posaconazole, candidiasis, cryptococcal meningitis we have fluconazole. As a prophylaxis for febrile neutropenia we have fluconazole. Treatment for febrile neutropenia we have voriconazole. As a drug of choice for invasive aspergillosis we have voriconazole. When it is not responding to voriconazole, the drug of choice for invasive aspergillosis is caspofungin. And we have a most wide spectrum of antifungal, that is amphotericin B. For systemic drugs for superficial fungal infections we have grisofulvin, anilamines, that is terbinafine, naftifine, and butanafine, which are and azoles, that is ketoconazole, fluconazole, and itraconazole, used orally as systemic drugs for superficial infections. And that's it for antifungal drugs. Thanks a lot for watching the video.